Hello, I'm Dr. Stephen Parr. I'm an emergency medicine physician at Tradition Medical Center. I'm also the ED medical director here at Tradition. And I'd like to talk to you today about heroin overdose and what it's like for a patient who comes in as a heroin overdose. So the first problem that we have is often nobody knows what anybody has injected into themselves. And often the person injecting doesn't know what they've injected themselves, because it can have any kind of adulterants in there, even things as odd as strychnine, just so that people feel different when they get it and they feel like they're getting high. But the most recent media attention has been to the very high potency opiates, fentanyl and carfentanil, with fentanyl being a medication that we use more in anesthesia and more in trauma setting to help people with pain. It's I think 100 times more potent than morphine. And so it's got a really narrow, what they call a therapeutic window. So it means that a little extra of it can be way more than you're used to and can actually kill you. The other problem with it is it's also super highly addictive, even more so than heroin. And then the carfentanil is, I think, 1,000 times more potent than heroin, and they use that as an elephant tranquilizer. So the people who are selling heroin are cutting that into the heroin to give people a better high, so that people seek out that medication because they think it's going to get them more high. The problem is that there's inconsistent dosing, and people aren't used to using that medication, and so it's really easy to overdose on that medication. So. And that's what we deal with here in the emergency department, is the people who've overdosed. So sometimes it's an unintentional regular heroin overdose. Sometimes somebody puts something in the heroin and it's just a hotter dose than the person is used to. And the problem with that is that in addition to the high that they get, it also cuts off your brainstem response to low oxygen levels and high carbon dioxide levels. So what that means to the person who's overdosed is that they're unconscious, they can no longer actively breathe for themselves, and their brainstem no longer cares if they breathe, and then that causes them not to have any oxygen in their blood and too much carbon dioxide, and that can kill off your brain. So usually the way that somebody presents here, if that happens for a long time, of course they die. If it happens for an unknown period of time, then either they have brain damage, or if they're lucky and somebody finds them in a short period of time, then the paramedics respond and we try and give them a reversal agent called Narcan up front. The Narcan competes with the heroin, and it will actually it's actually almost like the Uma Thurman scene in Pulp Fiction, where they just magically kind of wake up when you get it, assuming they aren't on one of the really high potency opiates like fentanyl or the elephant tranquilizer, the carfentanil. So the paramedics give them that medication. If they wake up immediately, then a couple of things happen. If you're on heroin, a lot of the time people are using heroin so that they don't end up going into withdrawal. And the withdrawal symptoms from heroin, they make you feel like you're going to die, but you won't. It's actually not a life-threatening withdrawal syndrome. But what happens is you start having nausea, vomiting, and diarrhea is the biggest part of it. And while the heroin is making you feel good, is hitting all those euphoria symptoms, and we use it to treat pain. When you reverse all of that, then all of a sudden everything hurts. Even a sheet laying on top of a patient hurts, and that's while they're usually actively vomiting in the floor, and they almost immediately start having diarrhea. So all that's the really unpleasant side of the reversal agents. If they're on a high potency reversal agent, then one of two things can happen. One, the paramedics may not realize that they really are a heroin overdose because they didn't respond as we typically see with the reversal agents, or they can the heroin, the high potency heroin with the fentanyl in it, can overpower the reversal agent, and they get repeated sedation. So those people may require higher doses of the reversal agent. So if, for example, we might normally give somebody 0.4 milligrams of Narcan, which is not a really big dose of Narcan, but if they're on a fentanyl-laced heroin, they may require 2 to 10 milligrams of Narcan to reverse the heroin. And it's not uncommon that we actually have to take Narcan and put it into an intravenous drip and run that into the patient to keep them from having repeat sedation. So the other things that happen are that people who inject heroin, it's generally very bad for your veins to do that over a period of months to years, and a lot of them don't have any veins left over. So if you're lucky, the paramedics can actually find a vein to be able to start an IV to be able to give you a reversal agent. Fortunately, if they can't do that, we actually have a nasal atomizer where they can actually spray it up into your nose, and that medication gets on the skin inside your nose, and you can actually reverse heroin by that pathway. But if they end up here, especially if they're on one of the high dose opiates, we're not going to be spraying fentanyl into somebody's nose every time they stop breathing. It's just not a really professional way to handle it. And if somebody doesn't notice that, then they can actually quit breathing and they could be harmed. So what we have to do is we have to get some kind of vascular access. So if they didn't have a breathing tube put down their throat to begin with, they may end up on a ventilator here with a big plastic breathing tube down their throat. And then the other thing we have to do, if we can't get an intravenous line in one of their arms or legs or hands or feet or their neck, then we'll take a central line is what we want to use. So we'll take a needle that's probably about 4 to 5 inches long, and you stick it up underneath their collarbone, and you know about where their subclavian vein is, and you put the needle in while you're pulling back on the plunger until you start getting blood back. Once you get that, you can take that off, and if blood's squirting out, then you know you're in an artery and you have to start all over. If there's just dark red blood dripping out, then you know you're in a low pressure vein that doesn't have a whole lot of oxygen in it. And then the process for that is that you run a wire into that vein, pull the needle off, take a knife, cut through the skin, and then there's a dilator that you use to stretch out the hole in the skin and stretch out a hole in the vein, and then we've got a big catheter that we can run in under their collarbone into the center of their chest. So now that we've got a secure line, so we know that those life-saving medications are going to get into their circulation, and they'll get into their circulation immediately. So in general, that's how a patient presents to the emergency department and how they get treated in the emergency department. And then after we manage that, they may end up being admitted to the hospital, and if somebody has hit that point in their life where they're so addicted to these drugs that they're a threat to themselves, then we actually may have to take away their right to leave the hospital. So one of the things that we have in Florida is something called a Marchman Act, and a Marchman Act means that someone is a threat to themselves or others because of a substance abuse problem, and because of that threat, we have the ability to take away their right to make decisions for themselves for up to 72 hours. So what we'll do is we'll invoke a Marchman Act, which is a legal process that allows us to take control of that person, and then we can send them for involuntary detox. So we can send them to a facility where they'll help them go through all those withdrawal symptoms over a period of several days and keep them from having access to heroin or any other kind of opiates that would keep them addicted. And of course, that's a very difficult process. Often there's limited resources, so it's not like somebody comes in as a heroin overdose, gets admitted to the hospital, they're better in 6 to 12 hours, and then less than 24 hours they're going to a detox facility. Usually that's a process that takes several days. And if a Marchman Act runs out, if it terms out on that 72 hours, then we'll have to reassess them, and we can invoke another Marchman Act and actually keep them longer than 72 hours.